Oh, yeah, and blessing. What will be your number?
A typical general hospital in Nigeria. Cramped. No space for meaningful healthcare delivery. Dilapidated physical infrastructure. Obsolete and decaying medical equipment. Less than sanitary operational environment. Tired and overworked personnel. Despite these, a large crowd of anxious patients waiting for medical care. This is the picture when the general hospitals are in operation. Oftentimes, incessant strikes over staff salaries and working conditions leave the hospitals shut for long periods of time. At such times, the hospitals are dark and empty, and sometimes they are used for activities not related to health care. This common thread runs through Nigeria's entire health sector. It's a story of neglect, and the consequences are glaring. Each year, about 59,000 women die during childbirth or from pregnancy-related complications. This is about 10% of the global estimates. Nigeria, with a population of 140 million, is second only to India, which has a population of 1.2 billion. Thousands of others experience injuries, infections, diseases, and disabilities that can cause lifelong suffering. Infant mortality is one of the highest in the world. Nigerians still die from preventable, communicable, and curable diseases like malaria, typhoid, cholera, diarrhea, and tuberculosis. In 2000, the World Health Organization ranked Nigerian healthcare system 187th out of the 191 countries evaluated. This is in spite of the fact that the country has 53 tertiary health institutions, over 1,000 general hospitals, and at least 100 basic health centers in each of the 36 states. However, a visit to the health institutions and an appraisal of the implementation of the health policy quickly shows why the country's healthcare delivery system gives little or no hope to Nigerians. Nigeria operates a three-tier system of healthcare with primary, secondary, and tertiary levels. According to the health policy, each of the three tiers of government has a responsibility for a level of healthcare. The local government is responsible for the primary health care services. The state governments are in charge of secondary care, while the federal government takes responsibility for the tertiary level. The primary level of health care is considered the most crucial for several reasons. It is rural-based, and basic healthcare facilities are located in communities where healthcare services are needed most. It is also the first point of call for rural dwellers who make up about 70% of Nigeria's population. It has the greatest potential to minimize maternal and infant mortality as well as deaths from preventable diseases because of its preventive and basic health care mandate. In spite of these responsibilities, the primary tier of health care delivery suffers gross neglect. With little or no funding, lack of qualified manpower, zero coordination and monitoring, the few basic health centers scattered around the 774 local governments are almost useless to their host communities.
For quality care, we have various elements of quality care. Do we understand? Yes. The very first thing is accessibility and availability of the care. And when we mean accessibility of the care and availability of the care, for example, a woman that is living at Abeokuta and needs an healthcare facility that is situated right at Ijebu-Ode, do we think it's very possible for this woman to access that healthcare facility? No. That means if you are going to talk about quality care, it must be within the reach of that patient.
Despite this basic teaching, the spread of health centers is so poor that rural dwellers are forced to travel hundreds of kilometers to access any kind of care.
Patients come to this hospital from the towns around. If, for instance, you go from here to Udi, there is no hospital in between. Government hospital. What do you have at the private hospitals? So those who can afford the private fees or fees of the private hospitals go to government hospitals where the fees are less expensive. So but if you had a hospital at Ngo, for instance, you have another one at in between Ngo and Udi, then it will reduce the surge to the hospital.
Some people, in the course of, in the bid to get far away for healthcare delivery, transportation takes even the money for, that they could have spent on their treatment. Say if somebody has 2,000 naira, perhaps he has malaria, he probably would have been able to buy the anti-malaria if he got meaningful help from the health center near him. Then by the time he now takes transportation, all the way down, he would have spent all that money on transportation.
Now, between that micro and Soka again, there's no government hospital. Big hospital, no general hospital. So you find that the city is thickly populated, and then the towns around it, the villages around it, also feed the place of patients.
When available, most of them are of little or no use.
The drugs are not there, and the equipment is not enough. Like now, Umuagu Health Center, we don't have oxygen. In case we deliver the baby that did not cry very well, we have to resuscitate, do everything, but no oxygen. We need oxygen, and at least van in Umuagu Health Center, so that in case we want to refer a patient, we use that van to refer immediately.
Every pregnant woman will take care of them free, both their tests and everything, their drugs and their treatment is free. Then you find out that sometimes there will be no reagents in the lab for the tests to be carried out on them. So you see, all these things, they are challenges. So if they actually that they want to reduce maternal mortality and morbidity in this country, they should try as much as they can to make sure that everything necessary for us to take care of these women, they are made available for us.
Some of these places don't have a small micro-hemato kit. The small micro-hemato kit that you can just use for PCV, which is less than 100,000. Some of these centers don't have. You understand what I'm saying? So how can you measure PCVs here? Even some centers who lack a BP measuring apparatus. These are many of the smallest things you can talk about, and yet they are lacking in some centers.
There, however, seem to be efforts in one or two states to improve rural health care. In Rivers State, for instance, work is in progress to put up standard primary health care facilities. Also in Ondo, there is the commendable Abiye Safe Motherhood Project, which is fast reducing maternal and child mortality rates in the state.
When we came on board, we were not happy with the health indices that we had. As a matter of fact, World Bank came here and told us Ondo State had the worst health indices in the southwestern zone. And they were going to sell the idea of an existing program called Health System Development Project, say 2 or so. And I just told them that much as I appreciate their effort, that we would like to do a completely homegrown program, and then I will invite them a year after to come and assess this program. So we put heads together and decided that if we could tackle the critical delays that lead to maternal death, we will probably be reversing this unfortunate maternal mortality figures that we have in Ondo State. And we also came to realization of the fact that part of the problem is that at policy level, we see statistics. We don't see human beings. And I told my people, statistics apart, let us be able to track every pregnant woman in Ondo State, right from the home level, community level, to facility level, until the woman delivers, and even track the child until age 5.
But these efforts simply disappear when put against the daunting challenge Nigeria has in improving rural health care and cutting the rate of unnecessary deaths. The next level provides secondary health care. This is designed to give specialized services to patients referred from the primary level. It is the first healthcare level which provides general medical, surgical, pediatric, and community health services on outpatient and inpatient basis. Secondary healthcare is the responsibility of the state governments. General hospitals, which mostly fall in this tier of healthcare delivery, are barely able to provide basic services, and the reasons are not far-fetched. In almost all the states of the country, buildings housing general hospitals are old, decaying, and grossly inadequate for their purpose. The General Hospital in Abeokuta, a facility built as barracks to house returnees from Burma War in the 50s, later turned into a hospital. A wooden building from the 50s still houses this ward till date. The Murtala Mohammed Specialist Hospital in Kano, built in 1926. The facility has gone through several phases, from district hospital to general hospital to teaching hospital and now to specialist hospital. Yet all these transitions have brought little or no change to the physical infrastructure. Urban expansion has caught up with the hospital, such that it is practically now in the middle of a street market. The Okwe General Hospital in Asaba, the Delta State capital, hardly any space for more than 30 beds. With a 3-bed accident and emergency session, there is definitely not enough room for people in dire need of prompt medical care. Apart from the dilapidated physical infrastructure, general hospitals across the country also lack basic medical equipment. Most of the time, hospital workers are on strike in agitation for better pay and working conditions.
We have about 19 general hospitals in Imo State and 256 health centers. Wonderful dream, but non-dysfunctional. The general hospital, which is in the city of Imo State, the general hospital we just visited, which is in the city of Imo State, is about the only one that has a little life in it. But I'm sure you've been there. Count the number of patients, it's nothing to write home about, because people have lost confidence in the hospital. Now, it's either the Federal Medical Center or some of the clinics that are around that see the patients. So the whole place requires total rehabilitation and renovation.
Medical workforce is inadequate and barely trained. This is made worse by state government's policies of free medical care for certain category of people without commensurate upgrade of funding, manpower and infrastructure. Of course, the general hospitals are overwhelmed by the teeming population of people who cannot afford to pay for orthodox health care.
We are so short-staffed. This is a 250-bedded hospital where we attend to everybody. And since the inception of the new governor, that is Governor Amusu, he has pronounced free medical health at the age of 0 to 5 and the pregnant women. So we have people trooping in that are coming, but we are short-staffed.
and it cut across all cadre, the doctors, nurses, attendants, lab scientists, the gatesmen, the laborers.
For institutions which have the sole responsibility of preventing and curing diseases, it should be a given that they will operate in a clean environment. Not so for most of the state-run hospitals. Operational areas are anything but sanitized. Some states also set up teaching hospitals to develop healthcare manpower. But such institutions are not treated any differently from the secondary and primary healthcare centers operated by the state government. An example is the Olabisi Onabanjo University Teaching Hospital in Shagamu, Ogun State. Upgraded from a general hospital to a teaching hospital in 1986.
It evolved from the former State General Hospital. The implication is that this is not a purpose-built teaching hospital. The ideal situation would have been to have a purpose-built teaching hospital right from conception through the phase of implementation of all the various components. What we have had is modification and restructuring of what was inherited from the state teaching hospital. In that respect, therefore, there is a lot of drawback.
From late 2010 to August 2011, no meaningful healthcare activities took place at the hospital. No thanks to a protracted strike over staff salaries and working conditions. One of the reasons for the strike is the absence of basic equipment for healthcare delivery. For instance, the hospital's laboratory has just one functional microscope, one functional but decaying refrigerator in its blood bank. The list of basic needs is endless. Yet, this is the only public hospital in Shagamu with a population of over 250,000 people.
The effect, of course, is that overall, we are not running at par with comparable facilities, even within this country, talk less of outside of Nigeria. Therefore, the extent of exposure of our medical students, our resident doctors, and even the trainers, including myself as a consultant, is sub-optimal, if I may put it that way.
One of the first things I did is my first real official engagement that I planned for, that I was in control of myself, was to go straight to that hospital, both to talk to the medical staff, to assess the situation, and to plan to come back for a more thorough situation assessment. But even that short visit that I did, which was mainly to discuss with the doctors, I was given a very heartfelt appeal from some of the doctors about the conditions, about the lack of staff, about the fact that really it's a teaching hospital only in name.
Even in Abuja, Nigeria's seat of power, government's inability to manage general hospitals has led to some of them being handed over to private individuals through a concession agreement.
The challenge that is there is part of the very rapid growth of the city. We are unable to meet that huge growth, commensurately in terms of having public health facilities to meet those demands. You'll also know that the concept of the city when it was started was every district of the city is supposed to have its own public health facility. And the growth of the city also meant that the existing facilities became sort of, roped in by developments around, so there's no room for expansion. So if you go to Asokoro Hospital, you go to Matama Hospital, there are developments all around, so there's hardly any space to expand those hospitals. So the hospitals that were initially meant for small populations now are having to deal with larger populations for the same size.
This action is gradually eroding the concept of building general hospitals for the welfare of the people, because they just cannot afford it.
They want to do, they will benefit from it. What of the common people that are suffering? Why can't we improve the general hospitals for the interest of the common people.
It is government that's supposed to hold this in so that we poor ones that living in this area can benefit from the hospital. But as in the Indian people are holding it, when they go for some checkup or anything, you see that the money they call for us is very high and we cannot be able to afford it.
The final tier provides tertiary care. This level consists of highly specialized services provided by teaching and other specialist hospitals. There are about 53 health institutions in this category, and they include 22 university teaching hospitals. Others are 17 federal medical centers, 8 psychiatric, 3 orthopedic, 1 eye and 1 ear hospitals. These hospitals have the responsibility of not only providing tertiary care, but also developing manpower for the sector and conducting research to improve response to diseases. In Nigeria today, these are the only public institutions which look and operate like hospitals. But even they are confronted with a myriad of problems which make the discharge of their threefold mandate of teaching, research and service delivery a near impossible task. The most crucial of such problems is funding, and managers of the tertiary health institutions are united in this regular sing-song.
Money is always a problem in this country. You know that bit. It's always a problem.
It's you can imagine how much diesel we consume. These big generators, how much diesel they consume. So the money goes. So our overheads are never enough.
In the area of care of our patients, the fund the government sent for caring for our patients, I've given you a scenario of a patient that is discharged and the residents could not be located. For such patients, we cannot drop him on the street and come back to the hospital. We have to bring such patients back to the hospital. Then who pays the bill? Who pays the new bill of feeding the patient, giving the patient drugs? Because if you don't give him drugs and you just bring him back here, within 1, 2, 3 months, it will have a breakdown again.
The federal government is the sole financier of tertiary health care. In 2000, Nigeria led 50 African heads of state to sign the UN Rollback Malaria Program, Abuja Declaration, an action which mandates the government to spend 15% of their total budget to fund health care delivery. The Nigerian government has not spent more than 5% of its annual budget on health care since the 2000 pledge. The excuse for not achieving this has become a refrain for government officials, including managers of the federal health institutions.
Government will say there's only limited resources, and those resources have to go around all the sectors. We're talking about power, we're talking about roads, we're talking about many issues, education and health. So government has limited resources to address all this.
Monthly allocation from the government is hardly regular, and when it is, the figures are inconsistent. What's worse is that though designed as tertiary institutions with a mandate to teach, research and provide highly specialized services to their communities, the hospitals have no funding for teaching and research, their core responsibilities.
The issue of training. We also have to do a lot of training. As I told you, right now we have almost 300 residents that we're training and over 100 consultants. And these consultants will have to also be going in for update. You see, the thing about medicine is that medicine is so dynamic. If today you use chloroquine to treat malaria, tomorrow it won't be chloroquine, it will be something else. So if you don't go for workshops and seminars and conferences, you won't know how fast the world in medicine is moving and will be left behind. So we encourage them. So there's a lot of also burden on the system. And really, we don't really have a training boat.
Their funds are broken into overhead, recurrent and capital. Even the capital projects to be undertaken each year are centrally determined and not according to the immediate needs of the institutions.
The funding, if you take different institutions, the pattern of getting capital funds to do some of these things has not been steady. It's not consistent. There are periods, prolonged periods in the past when there were no capital funds at all. So there was virtually no development.
Of the 53 federal government institutions, only about 12 are housed in structures purposely built for tertiary health care. Others operate from makeshift accommodation.
The institution started about 108 years ago. Started as a district medical center, moved on to general hospital, and in 1995 it became Federal Medical Center. So with all these movements, the changes in nomenclature, the changes in service, the mode and extent of service delivery, we did not have a corresponding enhancement of the infrastructure. And so we have grown and grown beyond what our current infrastructure can cope with. And at the same time, we do not have enough support service providers in the state. It's virtually Federal Medical Center where that caters for close to 90% of health delivery needs in the state and the environs.
In terms of expansion, we have not really expanded pari passu with the demands of the population growth. If you take the population of Nigeria in 1959 was actually around 40 million in 1959, roughly. Now, with a population of about 150 million, the hospital has not grown even 50%, you know, if you compare to that. Because up until, right from the original design actually, it was supposed to be in phases. So the two major wards, which you call West and East Ward, in the original design, they're supposed to have like a mirror image on the other side, which never came up. So that same structure was serving the hospital for like 30 years.
And we, because we're in a health-related industry, we find it difficult to turn back patients, and so we just try to cope on and on, but it's been extremely difficult. The environment, like you can see, is choked. You see how many the consulting rooms. We find out that in one consulting room, you will have maybe about 7 doctors, each with their patients, and probably the relation. So sometimes at a time, in a consulting, we have close to 20-something people. So that sounds like consulting in a marketplace. Some patients who are shy actually go away with some of their problems because they are not able to speak in that atmosphere where there are so many other people, and they imagine people are eavesdropping. And there are some kind of examinations that the doctor may want to conduct, but the environment is not suitable. So they just do the next thing they can do within the circumstance.
Uncompleted and abandoned projects litter almost all the institutions. Another challenge for effective and efficient healthcare delivery at the tertiary level is the dearth of medical equipment. Only about 10 of the institutions can boast of some level of modernization of their medical operations. 5 of these are the institutions regarded as centers of excellence.
In our radiotherapy department, we had a Cobalt 60 equipment which is used for the treatment of cancers. And we had that equipment for over 30 years. So the equipment was becoming obsolete. But fortunately, in 2007, the federal government of Nigeria gave us a linear accelerator, which is the latest technology in the management of cancers. So that equipment, made us to become more updated with regards to the management of cancers. In addition, under that re-engineering program of the federal government, we got 5 new theaters, which also has helped us to reduce patient waiting time for surgeries.
The others still make do with obsolete equipment and sometimes the ingenuity of improvisation just to get the job done.
No, he's picking it, don't pick it.
We don't yet have a CT scan. We don't yet have a number of imaging tools, mammography. We don't have a dialysis center here. and we do have a lot of patients who require those services. So when those kind of cases come up, we have to refer them for those investigations or for those interventions.
So sometimes you may find out that you are using one equipment today and tomorrow you may have a better one than that of the one that you are using. But somehow so good, some of the equipments we are having them, but the modern equipment, we are yet to have them. Yes, we are yet to have them.
The VIMET project is a federal government equipment standardization program introduced in 2002 by the Obasanjo administration to upgrade medical facilities in 14 teaching hospitals. 9 years and many controversies after, only 10 hospitals have benefited from the scheme. Even these complain that the equipment is not enough to meet their needs.
The government was magnanimous enough to have given to us facilities, equipment worth about 2 billion naira at that time. This was commissioned in 2006 with this permanent site by the former head of state, Chief Olusegun Obasanjo, at that time. And so there was quite some considerable improvement. But having said that, there is still a lot of gap. There is still a lot of gap. In terms of equipment, we are not yet where we are supposed to be as a tertiary hospital.
Another problem is that some of the equipment are either not fully configured or there are no trained personnel to operate them, so they lie in the hospitals gathering dust. Apart from this, running and maintaining the equipment are major challenges because of the erratic power supply in the country and the absence of maintenance expertise.
We have simple patient monitors. That is this thing that show graph by the patient bedside. What's the heart doing? What's the pulse doing? What's the oxygen saturation? And things like that. These are nice technological gadgets which we find very difficult to sustain because of power fluctuations. It's as simple as a gadget like that. The fluctuation is even beyond what the UPS or the stabilizer, can handle. So, as a society, I think, are yet to adequately tackle basic issues. But I think if we reorganize our priorities a little bit, the power we have, we should make hospitals a priority in giving that power. Now, if we get that, then we can now begin to talk about other issues of funding in terms of acquiring technology. Because, like I give an example from those monitors, it's one thing to acquire technologies, another thing to maintain and sustain them. And if you find basic ones that are not sustainable, you find that you cannot move to the next level.
Other federal government hospitals have learned to get along without modern equipment, even when they are available. An example is the Uselu Psychiatric Hospital in Benin City, where the only electroencephalograph, a diagnostic equipment used to measure the electrical activities of the brain, sits useless most of the time because there is no electricity to power it. And this is the only one of such equipment in the 6 states which make up the South-South geopolitical zone of the country. The Federal Medical Center in Owerri, the Imo State capital, had just 2 functional dialysis machines for the management of patients with kidney failure until a communications company donated another 2. Today, these are the only 4 dialysis machines in the whole of Imo State.
Many a times we have more patients needing dialysis and they will be waiting, the queue to wait for it. So since FMC Owerri is the only area where the federal government have an impact in things like dialysis, it means that many more patients are being wasted, are also being delayed, and not taken care of when these ones are used.
The result of the inadequacy of diagnostic disease management and treatment equipment is that patients are forced to travel hundreds of kilometers or wait in queues for weeks for health care, and most of them just don't make it. Yet others are forced to seek help in the dens of the ubiquitous quacks or unorthodox healers which dot every community in the country. Power supply has remained one of the most serious challenges of healthcare delivery in Nigeria. In most hospitals across the country, public power supply is hardly available, and when it is, medical equipment cannot be powered with it.
They were installed by Siemens some years ago, but we still have, because of this power thing, a power surge came and destroyed something in it for some time. We're looking for, people come and put millions to be able to fix. So we're still thinking about what to do. But otherwise, we didn't need to go send our patients elsewhere to do x-rays and all those things.
Most hospitals are without electricity supply for weeks on end. The few which cannot afford to leave crucial operations without power generate their own at huge cost.
We do have a dedicated line, and each time there is light in Kano, I know NEPA tries as much as possible to give us light. But on so many occasions, there is just no light. If you call a NEPA, they will just tell you they don't have that light. So what we do is that we have generators and generators and generators. We have a generator that's supposed to take the whole hospital. We have expanded so much in the last few years that that generator cannot take the hospital. So we now have satellite generators. We have a generator that takes care of intensive care unit. We have a generator for our radiology. We have another generator for our theaters. We have generator for the labor room and the special care baby unit. These are critical areas that we cannot afford to have a single minute of no light.
When we were commissioned in 2006 with the VAMED equipment, VAMED said that we cannot run their facilities with public power supply because of the quality. The quality was not good. And therefore, this hospital will virtually run on generators. Mandatorily from 8 o'clock to 5 o'clock in the very critical areas. It's only in very few areas that we can use NEPA power supply. And that has persisted up till now. And that is, has constituted a big drain on our resources. To maintain the generators, buy the diesel, maintain the switchgear and all that is tasking.
So we spend as much as 10 million every month to provide diesel to ensure that we have 24/7 electricity supply. And so that's a major challenge. And if you consider what that means every year the hospital spends in excess of 120 million to provide electricity, in spite of the fact that we pay NEPA bills. And if you translate that to 5 years, we're talking about 600 million. And you just imagine what a hospital can achieve if you're able to plow 600 million into other areas instead of I won't say wasting it, but that's the price we have to pay to be able to offer services under the challenging circumstance that PACN has put us.
Many others depend on domestic power generators like these for their operations. Despite this myriad of problems, hospitals at all levels have a huge population of Nigerians in need of health care to cater for. At any given time, the functional health institutions are, so to speak, filled to the brim.
John Ochenaland, you cannot come in together. John Ochenaland, Dr. Neba Gafun. 83, sorry. 83. Yes.
They cater for the very poor, the downtrodden. In fact, a number of patients we treat abscond. You know, some were even happy to let them go There are some that we have to send home with our ambulance just to be sure that they even free the bed for the next patient to use.
Like the Lagos University Teaching Hospital, UCH Ibadan has had to set up a family medicine department to take care of the growing number of people who walk in off the street just to get that first diagnosis.
The department has had to grow because we see probably about 2,000 patients every day, people coming off from the streets that need to be sorted out. A large number of these people, we just have about 30 to 40 of them that need to be registered and have a more intensive evaluation. If things were well organized and you had the family medicine physicians, for example, in the secondary level of care, you had a good primary level of care that was working and was only filtering out those patients who could not be answered at that level of care. They will go to the secondary level of care where the family physician will be able to take care of them. And usually research has shown that it's only 4% of these people that actually need to go to the tertiary hospitals. So definitely this is a testimony that our lower level of healthcare is not working optimally.
You know, we moved into this permanent site in 2006. We were at the former Port Harcourt General Hospital at the center of town. And our expectation at that time, because this place is a little bit out of town, is this place is in the outskirts of Port Harcourt. Our expectation then was that as we moved to this permanent site, that the demand for our services will reduce. But we were proved wrong. As we came in here, the demand increased tremendously. That on a daily basis, we are seeing over 1,000 patients in our outpatient services. And the bed capacity has increased. We are nearly 700 beds now, and it's still not enough. All our services are stretched. Our antenatal clinic is stretched. Our family general outpatient clinic is stretched. Our accident and emergency is were outstretched. So you see that many more people just come here.
This situation is made worse by the poor state of health care at the primary and secondary levels, as well as the fact that there is no effective referral system.
We're actually not doing the right thing. Not doing the right thing in the sense that this is a teaching hospital, it's a tertiary hospital. We're only supposed to be operating at the tertiary level. We're not supposed to be seeing every cough and catarrh. We should only see patients who are referred to us from the secondary healthcare level. But we find ourselves in a position where we are forced to provide primary healthcare services. So every cough and catarrh, malaria, they come here. We are forced to provide secondary healthcare services and then the tertiary healthcare services. But we find ourselves, because we're overburdened by primary and secondary care, the tertiary healthcare services seem to be suffering.
It's the same thing in any teaching hospital you go to. The crowd. Most of these patients stay here all day just to get a card. Now, what's unfortunate is that most of them have cases that could easily have been taken care of at the secondary or primary healthcare level.
The person offering care in the primary health care system in Nigeria today is completely divorced from those offering care in the secondary, at the secondary tier, and also divorced from those offering care at the tertiary level. So the patient who is seeing a health care professional at the primary level has this feeling that he or she is not going to get the best. Whereas if there is evidence that there is an ongoing collaboration that does not deny the patient of the best care possible, then a patient will have every reason to stop by at a primary health center, knowing fully well that if the matter is beyond the primary health care physician or practitioner, there will be a next point. Right now, what seems to be happening is that the patient who knows, who has enough knowledge about what is required to take care of his health, will not walk near a primary health center because he or she does not believe that there's anything there to offer.
With these crowds of patients, the Nigerian health sector also has to contend with an acute shortage of manpower.
In the outpatient department, just outpatient department, per day, we used to see 7,000 patients. In the maternity unit, in a day, we used to receive 50 normal deliveries. In a month, cesarean section, in the maternity unit, we used to conduct 172 cesarean sections. So with this little overview, you can see the ratio between 1,772 against this lot of work that I am now making it. And don't forget that the total amount of this 1,772, we have non-professionals. So if you look at the figure, you find out that we need more staff in order to meet the new challenges that every day is coming up.
UCH Ibadan is Nigeria's premier teaching hospital. 54 years after it was set up, and many more teaching hospitals after, Nigeria still lacks the needed human capacity to drive the health sector. Nigeria, a population of 140 million, has less than 150 eye specialists, making it absurd to suggest a 1 to 1 million ratio. There are 100 ear, nose and throat specialists, 120 psychiatrists. The list goes on.
If you look at the doctor-patient ratio, or the doctor-nurse ratio, or the doctor-pharmacist ratio, I mean, it's appalling. There is no way you can have good health with that sort of ratio. Nigeria is fast growing in terms of population. At the same time, we need to consider human resource for it, which means we need to invest in human resource, which means we need to invest in our teaching hospitals.
There are about 200, but the issues we discuss about is how many of these 200 are available, even the ones in the country. How many of these 200 are available to really get involved in delivering eye care services? And there are many other issues. People are trained, they go do other things, or they leave the country. So we can, on the average, maybe say 150 are available to deliver the services. And I'm sure you can know that is grossly inadequate.
Across the country?
Across the country, yeah.
How many are available to this institution?
We are, the consultants were 11, then the trainees are about 29, so we're about 40 available.
The irony is that an estimated 25,000 Nigerian doctors practice in the United States alone.
The reason why a lot of doctors leave the shores of this country are multifactorial. Some leave to train properly and come back. Sometimes they get caught in the web of the glamour and the good life in the civilized society. Some leave because they're fed up with the system, and yet others leave because they can't find their bearing in the country. However, I believe that there are three categories of doctors who are, within the country. Those who are staying back in Nigeria because they love their country. Those who are staying back because it's a very good means of survival, because, being a doctor offers you some good life. You may not be a multimillionaire, but you're comfortable enough to eat 3 square meals a day. And some stay back because they haven't gotten an opportunity to leave the country. The brain drain is an unfortunate scenario. Of course, doctors are not as well, they're not well paid compared to their colleagues abroad. But I don't believe that that is the mainstay of the brain drain. There is this inferiority complex. People have this complex, that if you haven't, gone abroad, then you probably have not arrived with your colleagues.
Well, depends on how you look at it, whether you want to look at it with a positive perspective or from a negative perspective. If you look at it from a negative perspective, you say it's brain drain. But when you look at it from a positive perspective, well, we're exporting manpower because many of our professionals, and of course it's not a hidden fact that if you go outside this country, you have very well qualified Nigerians who are doing the, if you put it in quotes, miracles abroad. They're Nigerians. They started from here. Our undergraduate medical education is still very sound, still very good. Postgraduate is still very good. But the technology to go with it, the sophisticated equipment, exposure to those procedures is what is lacking.
The result of all these challenges is that hospitals in Nigeria only serve between 5 and 10% of their estimated coverage population.
The Nigerian populace is underserved when it comes to healthcare delivery. It's a belief, and that is predicated on the fact that as a teaching hospital, we see well over 150,000 patients every year. Far above that in terms of outpatients. We are not talking about inpatients, people who just come and go, who pass through our general practice clinic. I believe that that's as a result of the population outstripping these facilities. In this town, as it were, you have the specialist hospital run by the state government and UBTH. These are the two key hospitals in Benin City. The population of Benin City, I'm sure, cannot be in any way less than 800,000, if certainly it's not up to near 1 million. Because if the entire state is about 2-point-something million, I believe that most people are concentrated around Benin City and its environment. So you expect, therefore, that if just 2 hospitals with a total bed capacity of maybe 800, combining Central Hospital and UBTH, they take care of 800,000 persons, maybe a total capacity of maybe 200 consultants, taking care of 800,000 persons. You expect that that would be insufficient. So in that process, patients are forced to go to specialist hospital. Central Hospital is a specialist hospital, UBTH is a specialist hospital. There's no general hospital in Benin City.
If you look at our community, for instance, there are literally no effectively functioning primary care facilities. There's really no secondary care facilities around this place. So everybody from the immediate community of this teaching hospital comes here as their first port of call, which is not the ideal. It distracts attention from those who really need the specialist care at this level. And that throws a lot of burden on the caregivers.
Most people, including government officials whose responsibility it is to make decisions that will improve the sector, seek medical attention in India, the United Arab Emirates, the US, and Europe for common ailments. This is in a situation where Nigerians are daily inundated with broadcast media appeal for funds by poor but desperate people with life-threatening ailments seeking medical help abroad. Yet a majority of Nigerian populace turn to spiritual homes, traditional birth attendants, and other unorthodox places for help. An expression of lack of faith in the Nigerian healthcare system.
Okay, please.